So the background. It is important to recognise that the model that we undertook in Invest to Save, which is the prudent prescribing of human insulin, was on a background of a further community model that we started in 2008 to 2010. And what we recognised was that the management of a chronic disease like diabetes was very fragmented in Cardiff and Vale, and primary and secondary care didn't have good communication. We didn't really coordinate our care between the two services, so that patients would be referred into secondary care and they would wait 6 months on a waiting list, and then the decision that was made in relation to the question that was asked would often be a little bit out of date. There was lack of continuity and possibly not very good follow-up from secondary care's perspective. We also recognised quite a wide variety in practice across Cardiff and Vale. And so what we did 10 years ago was we allocated every one of the 63 practices a named consultant diabetologist to provide mentorship and support for diabetes services. What that meant was that when practices wanted to refer into outpatient services through WCCG or WPRS, that referral was automatically routed to the mentoring consultant, and they could accept it, refuse it, or ask for more information. But equally, when GP practices wanted advice on patients but didn't see the need to refer into a hospital service, that could be provided by e-advice, which is an electronic advice service that most specialties are signed up to now, and that referral would also be automatically routed through to the diabetologist responsible. And this starts to develop a close link between primary and secondary care, where we develop a confidence in each other's management skills, but also are able to provide mentorship. And as part of that, we also provide at least 2 visits to primary care practices every year so that we can discuss case notes reviews, maybe disseminate best practice guidelines, that sort of thing. So this started about 10 years ago. What we found was that having established that model, that primary care became much better able and more confident in managing all aspects of diabetes. And we're talking about type 2 diabetes here, not type 1. They became better at initiating and titrating therapies, including injectable therapies like GLP-1 analogues, and that resulted in fewer and more focused referrals into secondary care. And as a consequence, we were able to reduce our waiting times from 6 months to 6 months to 6 weeks. The one thing that practices identified as top of their wish list was better access to diabetes specialist nurses without having to go through the consultant in secondary care. But there's no resource. So how do you achieve that? We started to look at our own practice in terms of prescribing, and I certainly was quite surprised to find that we spend £1.3 million in Cardiff and Vale every year on Lantus alone. And we looked at all of the prescribing, but Lantus stuck out like a sore thumb. And we asked ourselves why this was. And the main benefit from initiating Lantus in type 2 patients is not clear, because Lantus is a long-acting insulin, as you know, which has a low hypoglycemia risk and enables more rapid titration in patients who have good control. But in most type 2 patients where you're initiating insulin, the patient doesn't have particularly good control, and that's the reason for initiating insulin, and therefore the hypo risk is low. So we asked, could we change prescribing habits, and could we use any cost saving from that to fund a diabetes nurse service? But in order to do that, you have to provide the nurses. You can't just switch insulin and hope the patient is well. They may have hypos, they may have hyperglycemia, and they have trouble with the device. So you need to provide support. So that leads us on to implementation. Because Cardiff and Vale didn't have access to a fund that we could easily tap into, we looked at other sources. Now, the Welsh Government have an Invest to Save fund, which is not a, you don't get given money that you can spend on whatever you want. It's a loan. But you don't have to repay that loan immediately. You can defer the repayments by 1 or 2 years, which allows you time to start to build proof of concept and make some savings before you're tasked with paying back the money you've borrowed. And our application was predicated on 2 principles. And they were that the cost of the nurse would be more than covered by the cost savings. And at the time, Humulin I, which was the insulin that was most commonly used in human form, was 40% cheaper than Lantus. And now it's a bit less than that, 30% or a little bit less still. But there's still a significant cost differential between the two. And the second one was that we would do no harm. So we were a little bit conservative here in what we aimed to achieve, because we weren't confident that by switching insulin, we would improve glycemic control. And what we decided was it would be better if you're adopting a switch policy with a product that has the potential for harm, that we could demonstrate that we didn't do any harm. And that was all we set out to demonstrate. And on the basis of that, Welsh Government offered us funding for 2 whole-time equivalent Band 6, which is the band that our secondary care nurses work at, diabetes specialist nurses for this project in the community. We appointed 1.8 because of hours worked by the 2 nurses, and we recruited in April 2016. So that date's relatively important. By the time the nurses had been appointed, trained, gone through all their accreditation and become independent in terms of their ability to work in the community, it was around September before the project actually got up and running. So it's important to recognize the community diabetes model that I talked about in the first couple of slides, starting in 2008, 2010, because what that did is that established very close links and collaboration between primary and secondary care. And it meant that we already had a working relationship with named people in those practices. The other important part of this, at least from our perspective, was the very close collaboration with Lilly, the pharmaceutical company. And obviously they provided support in a non-commercial and non-promotional way. But what they did was they offered us a software tool called Prudent. And Prudent is essentially a front-end tool that sits on GP practices, EMIS and whatever other software you use. And it can interrogate that system and provide you with a list of patients that meet certain criteria. And so our entry criteria for this study were type 2 diabetes, age between 40 and 75, with a poorly controlled HbA1c of 70 or higher, on Lantus, or a BD analogue mix, such as Humalog mix 25 or Novamix 30, with or without oral agents that would continue, and willing to consent. And what we aimed to do was switch the Lantus to Humulin I or the analogue mix to Humulin M3. But that was negotiable with the patient, and they had to be confident that they were happy to make that switch. Assuming they agreed, we gave them an initial appointment where they signed up to everything, and then we saw them with the diabetes nurse saw them at 1, 3, and 6 months. And all being well, at that point, they were discharged back to primary care. But we also endeavoured to make appointments available at short notice should patients become unwell. So the partnership and team working element of this, it's extremely important. And I think, although I'm talking about what went very well in this project, there were some difficulties, and we could have identified and advertised what we aimed to achieve more quickly, because it was seen very much as a cost-saving exercise. And in fact, the rationale for this was to provide funding for a service development that had been identified by primary care as highly desirable. That is, a community specialist nurse service for diabetes. So the existing links were important. They allowed us to get up and running within a few months, whereas I think it would have taken upwards of a year had we not had those links. Confidence and trust is very important. It's very easy in secondary care to give the impression that you're masterful and know what you're doing in a specialty area. But actually, GPs have a great deal of knowledge about diabetes. And it's important to provide mentorship and guidance to allow them to apply that knowledge to the vast majority of patients who are managed exclusively in primary care. And it was important for us to make it clear to GPs that we weren't auditing them or criticizing them in any way. We were simply providing support. As I've mentioned, the role of Lilly here was important, not just in providing the software tool. They did a lot of the groundwork, going out to practices, telling them what we wanted to do, setting the scene for our nurses to go in and hit the ground running. The nurse or nurses themselves are also very important. It won't come as a surprise to you that you need people who are highly motivated, capable of independent practice, and who are willing to build bridges and make those links and liaisons that are important to the success of the project. We're talking about 63 practices, but there are 66 to 69 when you include the satellite areas. So, on to the results, and I hope you'll find these persuasive. The results, as you're probably aware, come from the All Wales Medicine Strategy Group documents, which are published quarterly. And they have a number of prescribing indicators that this group and others feed into. So what you see in the left-hand panel here and the right-hand panel are the same thing, but the left-hand panel starts in, I can't read this without, even with my glasses, 2011, I think, up to March 2018. And the right-hand panel is 2015 up to December 2018. So in the left-hand panel, what you see in Cardiff and Vale in blue, the dark blue line runs horizontally to slightly increasing in the first few years. Then it starts dipping slightly. This is before the project and probably largely due to SGLT2 uptake, which meant that fewer patients were being transitioned to insulin. And you can see there's a sharp downward trend, and that corresponds to the September-December transition, at which point the nurses' activity started to become evident. So the graph shows you primary care data, and as you can see from the top, it's long-acting data prescribing of analogues versus human. So a dip in the graph is showing you fewer analog prescriptions, and therefore we assume more human prescriptions. But I haven't shown you the human prescriptions individually. In the right-hand panel, you see the latest data published, at least at the time this was submitted last week, and that's up to December 2018. But you can see that Cardiff and Vale, again in dark blue, continues to show a downward trend in analog prescribing. And I'm proud of the fact that this trend has put us top of the quarterly league for most of the sessions that this project has run in terms of primary care prescribing and drop in analog prescribing. The secondary care data is shown in this graph, and Cardiff and Vale is the blue line, which you see at the very bottom on the right-hand side of the panel. And you can see that from July to September 2016 and onwards, there's a very sharp decline in secondary care prescribing of analogues. Now, we were able to influence our own activity a little bit earlier than that of the primary care and groups, because we were obviously able to start that straight away. So you see a slightly earlier dip. And you can see about a 20% drop, which is a big drop. These are raw figures. So these are taken by our pharmacist colleague, Emir, and I think they're taken from Casper, but these are absolute figures in terms of prescribing. So these are real-world savings. So in the left-hand column, you see the cost of basal analogues and basal and premixes, including degludec. Now, strictly speaking, this project doesn't have anything to do with degludec, but because degludec was a relatively new insulin, and we were concerned that the uptake of degludec would interfere with our figures, we decided to include it to give a worst-case scenario. And then what you see is that the cost of prescribing falls from £160,000 to around about £130,000 per month. The cost of human prescribing in the middle column increases from around about £18,000 to £29,000 per month. And on the far right-hand column, you see the absolute savings. And you can see that it takes about a year or more for those savings to start really accruing. But once they start, there's no reason why they shouldn't continue, because the patients stay on human insulin, and those savings are therefore incurred month on month. So despite the project starting 6 months after recruitment, and unfortunately finishing 6 months early because of staff shortages, so we ran it for 2 years, we recruited around 400 patients. We have saved to January 2019, in absolute terms, £383,000, but probably more by now, which more than pays for the nurse salaries. It's more than double that. What surprised us was the A1C figure. So that figure that you see there is an average A1C reduction across the patients we optimized. 13.9 millimoles per mole reduction. That is a massive reduction in A1C. And what it tells us is not only can you do no harm, but you can do substantial good with these sorts of models. And it clearly isn't the insulin that's important. It's the nurse time, it's the support, it's the education. The project also is successful not just because of the switches, but because fewer analogue insulins are now initiated in primary care where those practices initiate insulin and in secondary care. And what we also see is that it's a win-win situation. We get funding for specialist nurses in the community that didn't exist before. The UHB gets over £200,000 savings so far. So the final slide is just the conclusions. I would suggest that the project, as we implemented it, is very heavily dependent on the relationships that we already had in primary care, but it wouldn't be impossible to start them from scratch. A strong sense of co-working, mutual trust and respect is really important. The pharmaceutical company engagement has been invaluable. They continue to support us with writing up the project reports for Welsh Government, which are not arduous, and they also provide a lot of administrative support. It's important, I believe, that secondary care leads by example. If you go into primary care and ask them why they use Lantus, the most common answer you'll get is because you initiated it. And that's important to remember. We forget this in secondary care sometimes. And I would suggest that this is maybe just the tip of the iceberg. We have an awful lot of prescribing, over £1 million on DPP-4 inhibitors in Cardiff and Vale, but also GLP-1 and SGLT2 agents, all of which have stop criteria, most of which probably aren't scrutinized to see whether they're effective within the time frame that those stop criteria apply to. But if you're going to start that project, you need to support the patient. You need to monitor the HbA1c, and you need to be confident that if it deteriorates, you can either restart the product or find an alternative. So I would suggest the Investor Save model is a good way of saving money, but actually it improves patient care and it provides service development opportunity that will provide longevity to a community-based service. And the savings build on year as long as the patients don't return to their analogues. So that's a very brief whistle-stop tour of what we did. Thank you for listening, and any questions?